So I'm going to talk about a topic that a lot of us like to bury our head in the sand about, not really imagine that something like this can happen in our ICU, and specifically, what happens if someone brings a disease into our ICU that can potentially kill us, our staff, other patients, patients' families, and really ultimately can cause catastrophic failure of your ICU. And I hope by the end I am able to impart to you that it's not necessarily about the specific disease. There are a lot of different alphabet soup about diseases that come and go, but it's really about the same systemic catastrophic vulnerabilities that we have when we're trying to provide high-level, time-sensitive care and also consider being able to protect ourselves. So these are my disclosures. Nothing that I'm going to talk about today is related to any of the products or industry consulting that I do. So setting the expectation, many of you probably came thinking that I was going to give you a litany of things that you could do, a checklist to go home and try and make your ICU prepared. And for any of you that have been working in ICU preparedness and response, you know that actually the checklist is very long, and it really goes across a broad range of different topics. This morning, there are going to be other presentations on critical care preparedness to infections, and that's really where we're going to get into the details, the A to Z, soup to nuts of what you can specifically do to make your ICU more prepared. Instead, I hope you'll humor me and allow me to talk about things that I've seen time and time again over the past 15 years of outbreak investigations that I feel are key vulnerabilities that unless we come together as a critical care community, decide to take them on, we're going to continue to have talks that really talk about the challenges of ICU response to outbreaks rather than just talking about patient management. We have to stop talking about when the ICUs actually fail and instead talk about what we did to be able to care for our patients. So respiratory failure is obviously an everyday occurrence for many of us who are taking care of patients. We'll start with a case, and it hopefully will provide some guidance on why this is such a challenge. So 50-year-old woman comes to a small to moderate-sized emergency department, moderate comorbidities, and she's fairly sick. They put her on high-flow nasal cannula, and her x-ray looks like that. She gets admitted to their ICU, and she crashes overnight and gets emergently intubated. The next day, the day attending comes in. They had not admitted the patient the night before. They saw the vent settings, say that's about what the max of what we do in this community hospital. We're now going to refer them on to a referral center. So they make the referral, and of course, the person who's providing the information is doing their best to take care of the patient, but they don't know all the details because the history is somewhat scant from the documentation the night before. The referring intensivist, again, tries to provide some details, and the accepting center says, absolutely, we're glad to take your patient. Patient gets put in a helicopter, put on a transport ventilator, comes in fairly sick. We do pharmacologic and mechanical interventions to try and get them stabilized. We're able to stabilize them. Patient's prone. And then they continue to progress. And ultimately, at this particular center, their practice pattern is to cannulate for veno-venous ECMO. The patient's put on ECMO. You get good flow. Actually, the patient's quite stable now. The ventilator is weaned. The patient gets a bronchoscopy, and no etiology is determined. That actually is an everyday case. However, what's the difference? The difference is 4 to 5 days later now, patients at that outside emergency department, as well as their staff, start coming down with a kind of non-specific respiratory symptom, and some are starting to get sick. In addition, at the referring hospital, we actually now see a fairly large cohort of staff who are actually very sick. And those staff obviously had not isolated themselves because they were just managing an everyday patient. So they've been intermingling with their family, intermingling with other staff, intermingling with patients and the patient's family. And until all of this happened, no one put the connection together that this is all related. Obviously, now the flare has been shot up, infection control gets involved, public health gets involved, and they discovered that that woman actually had been in Europe And she went to a meeting and had a colleague there who had been from a country where there was a small simmering outbreak of an undescribed respiratory infection, and now the disease has spread to your ICU. So how could this happen, right? Well, a lot of the infection control proponents would say, well, shame on us as clinicians that we didn't recognize, that we didn't isolate, that we didn't use proper PPE from the beginning. And there is some truth to probably we can do a little bit better at that. But I hope to talk with you about their extreme challenges of just putting it on the clinician to be able to identify that case and for the light bulb to go off and realize this patient is different because they look just like what we do on a daily basis. How many of you would have isolated that patient with the story I told you had you not been in a lecture about diseases that can kill you? Right, not that many. And then even if you chose to, which PPE would you use? Would you use the stuff that takes 10 to 15 minutes to get into? Would you put that person in a containment unit that it takes essentially an act of God to be able to open up for something that you don't even know is happening yet? So going back to the case, I think I want to reflect on some of the care issues that are at odds with the expectation that we're just going to be able to identify a patient right from the outset and know that they're at risk to us and our staff. We manage a lot of patients like this, right? We manage 100 to 200,000 patients with ARDS every year in the U.S. alone, and very few of them actually have a disease that can transmit to healthcare workers. We also care for people across a number of hospitals. Patients don't go to the Ebola treatment unit or to a specific unit when they present. They go to their local hospital. And there are 5,000 plus hospitals in the U.S. And we know from our safety literature that it's hard to imagine that all of those are going to be able to identify these patients just from the outset because there's so many competing priorities that they have in being able to provide time-sensitive care. It's also just really hard to get a good history from someone who's pretty sick if they don't come with family. In addition, some of the things that we do to manage these people may not be good for transmission. So, high-flow nasal cannula, we do not know what that does to transmit infection if people are shedding virus from their upper respiratory tract. Intubation, we know that that's been a problem in previous outbreaks, but should that, intensivist who was at the small hospital, who was probably the only clinician in the hospital, together with their staff, should they have delayed that intubation, even though it was a crash intubation, for a what if, or should they just go and be able to improve the patient's gas exchange? And then ultimately transfer. Transfer, of course, from an infection control standpoint, is a way to keep moving infection from hospital to hospital. But the flip side is we know from CSER trial and other trials that actually referral patterns actually can make a difference in people's lives on an everyday basis. So it's a good thing for most times to be able to get someone from a place where they feel like they've exhausted all of their resources to a place that's more comfortable being able to provide additional tools for someone who's trying to die. Once you get to the referral side, there are some things that continue to be a problem. The transport ventilator, usually there's not a good standard on whether or not we should be filtering the exhaled gas. Same on a full feature ventilator. There's not a lot of consensus on whether we should filter the exhaled limb and what size filter we should use. And then coming back to recognition, should the intensivist who was providing ECMO have recognized that this was something novel when they didn't get an etiology back? I see some friends from shock trauma here, and this is actually a common occurrence for us. And in fact, this was a real case, except for the poetic license I took about the illness. In terms of we do not get etiology quite frequently on these patients. And yes, it probably should steer you towards maybe this is something new, but it's not a slam dunk to say, oh my God, we need to call the cavalry in, because this is something we probably see at least on an every other month basis, maybe even more frequently. So am I starting to set up and talk about, the world is going to end, the zombie apocalypse is going to happen, the meteor is going to hit? Or is this something that actually does happen? And we really started to learn our lesson from our Canadian, Hong Kong, and Southeast Asian colleagues with SARS. Obviously, I don't need to remind everyone of the incident in Dallas with a patient who had unannounced imported Ebola and the subsequent impact that had on that facility. Although many of you may not know that a similar thing almost happened in a New Jersey hospital even after our sensitivity to the possibility of Ebola was rising. A patient came back from Liberia who was in the mining industry, went through screening, became symptomatic, didn't tell anyone, went to the hospital, did not mention that they had been in Liberia, and fortunately the patient didn't have Ebola. Unfortunately for the patient, they did have Lassa and they succumbed to it. So the consequences are real. These are things that are happening, and unfortunately, even in places that don't have a lot of this disease, when it gets into your ICU and it's unannounced and there's human-to-human spread, it's game on. This is from South Korea just in the past year, where they had never had a case of MERS, so of course their suspicion was not very high. Someone came in with nonspecific symptoms, and ultimately it led to 33 deaths and 184 cases. And just recently, you would say, okay, maybe this is in countries that have low suspicion. How about in the Kingdom of Saudi Arabia just in the past 6 months, where they're actually experienced with MERS? They had an outbreak of MERS again, despite having several years of experience with MERS, and it ultimately led to 43 healthcare workers getting infected. So the story keeps continuing, and the stories are real. And they're going to continue because of the human pressures on ecology, where we are really changing the way humans and animals interface. And most of these infections come from animals. They're called zoonoses. So they change species, they come into the human population, and if they can spread from human to human, that's where the problem happens. Historically, that would also start to burn away because there wasn't worldwide travel. But you add those ecological pressures together with the fact that now new generations move throughout the world in a moment's notice, you can imagine that something that starts in one part of the world could be in another part of the world in the same day. And the case of the businesswoman is actually very plausible. This is what happened during SARS. A physician from mainland China went to Hong Kong, stayed at the Metropole Hotel, was on the 9th floor in room 911, you can't make that up, and ultimately transmitted disease to people who were traveling from a variety of countries, and that was the push towards a whole bunch of outbreaks in a number of countries. So why am I talking about this at a critical care meeting and not in a public health meeting? It's because outbreaks ultimately that cause severe disease cause organ dysfunction. And in places where organ dysfunction gets supportive care, ICUs, it's going to disproportionately impact us. When you look at SARS, again, there was a higher percentage of patients who ended up in the ICU. And it's not just the numbers, it's also the duration. As we know, the syndromes that people have, such as ARDS, don't get better in a day. This is not a quick response and then it's over. These folks we need to manage for a while. And this is from Rob Fowler's publication back in SARS that reminded us that most of these people were in the ICU for at least a week. So it's numbers and it's duration. So you need to be responding at very high intensity as healthcare workers are getting ill for quite some time. And I would push that it's not numbers for disasters, it's contagion. Contagion continues to be the challenge. I'll give you an example. When a regional hospital in Joplin, Missouri got hit by a tornado several years ago, that facility was just wiped out. It was a direct hit, and you can see their rotor wing, what happened to that there. That facility and their region around them pulled together and actually evacuated nearly 30 ICU patients in their entire hospital without any federal assistance. So I was in the federal government at that time. Our only job was to help with identifying fatalities. So we had nothing to do with the response because they were able to manage. Of course, in after-action reports in all disasters, I'm not saying that non-contagion, we do everything great, but we do pretty good. We still have the same challenges of communication, of data that's not being shared properly and lagging. So we can do better, but it is not a catastrophic failure of the system. Almost always, care continues on in any region during most disasters. But that wasn't true for SARS, and it hasn't been true for a lot of outbreaks, because they're an existential threat to the provision of critical care once you have unrecognized contagion coming into your hospital, both because of the fear and the draconian techniques you need to use to be able to stop transmission in its tracks once it's there, makes it where actually regional critical care is at risk. And we'd like to pass the buck, right? We're now hearing about the government supporting different specialized units. They're mostly around Ebola, but maybe they'll be able to be used for other facilities. When those facilities were actually surveyed and asked what is their bed capacity, so not even their capability, it was 120 beds for the entire U.S. And just to put that in perspective, the hospital I work at has more adult ICU beds than that entire capability, and the U.S. has 90,000 ICU beds, and the best we could do currently with the specialized centers is 121 beds. So it's going to be on us to be able to respond. So several years ago, when I first started this, I was really in the camp of saying, yes, this should be the new normal. Every patient we see, we should be in a full body condom and we'll be able to take care of everything, right? Well, that's really a strategy that I think has failed. And we've learned over time that just, again, kicks the can down the road rather than getting at the vulnerability that we have. And what's the challenge? The challenge is the risk to any specific unit any of us work in is relatively low, right? You just may be unlucky if it comes to you. But the risk overall to the ICU community is high. We know that these things are going to get into an ICU. We just don't know which one. So expecting everyone to be at a level of preparedness that's 24/7, 365, we know in the safety culture just doesn't work. And you never know where the patients are going to go. The first U.S. patient of MERS went to I believe it's Northwest Indiana, went to a moderate-sized community hospital in Indiana after providing care in Saudi Arabia, and he didn't even know he was taking care of patients with MERS there. So the real-world landscape, I think, has to make us recognize what are our true challenges. We have many competing priorities. Yes, this is something that some of us focus on full-time as our career, but we can't ask the entire critical care landscape to be prepared for a what-if that is so rare. We have small operating margins, so to put out big resources for this is just a non-starter in this environment. Also, the flip side is how many people will we hurt if we start putting on this draconian PPE that takes 10 to 15 minutes to get into before we actually start providing them care. There are a lot of patients who need us at the bedside like that, and we need to start providing care. There's another downside that was shown from Hong Kong, that when they started using PPE during SARS, they had dramatic escalation in nosocomial transmission of different pathogens. If you look at the white columns, those are changes during the outbreak. The hashes versus the solid lines. The hashes are pre-outbreak, the white is during outbreak, and then the black is post-outbreak. So you can see that just adding PPE, even though you would think would make a better difference at reducing nosocomial transmission of many pathogens, actually the way we use it puts people at risk. This was not verified and validated in the Canadian data, but it sure is something to take pause about, rather than just asking us all to do the new normal and wear very aggressive PPE for every single patient. So I do want to, just as an aside, let you know there are many other things we need to do besides talking specifically about our key vulnerability. We'll be talking about some of these issues in the rest of the meeting this morning. But the key thing to note is there are certain things that need to happen at the ICU and community level, and other things that all of us as a population need to work with our professional societies, our governments, our international professional societies to be able to provide consistent guidance, because right now almost no one thinks about ICU-specific stuff in outbreaks, even though we're consistently the ones who are impacted. Most of the recommendations are for the general hospital or even the community population of provision of care. So I would argue our key vulnerability is we need to change the way we think about infection. And we all know about never events. Well, I personally think that a healthcare worker infection has to go away from blame, and it needs to be a never event. And if it happens, we need to do root cause analysis, and we need to fix it immediately rather than just tracking the epidemiology of the illness and death of our colleagues. So why should you and I care? Because it's going to happen. It's going to continue to happen until we stop it. So the blue circles on this, sorry it doesn't project very well, are healthcare workers. The upper two are two different MERS outbreaks. The lower two are SARS outbreaks. And you can see there's a fair amount of blue on this slide. And in the upcoming year, as we're all planning to go to Oahu next year, what's going to happen? I'm not sure. We may be having more discussions about a new infection, about recurrence of different infection, or hopefully it'll just be a benign year. We don't know, but the vulnerability exists. And here's the way I truly see the vulnerability. What we've done is we have pushed this, or not we've been asked to shoulder the burden of having to recognize, isolate, have enormous suspicion, and then use PPE that we use periodically, use it properly, which gets in the way of the things we need to do to take care of our patients who are trying to die. It's very hard, as all of you know, time sensitivity matters in the ICU. And that challenge is really hard to be able to make parallel to staff safety. So we need to have a different way than just saying it's the staff's fault because they didn't think about it and they didn't aggressively use PPE. I believe this is a setup for failure, and we've seen that. In fact, I haven't heard of a successful use of this since we've been doing this for about 15 or 20 years. And even after we know that events are going on, we still struggle because a lot of patients don't present normally. So when you look even at SARS in the US, you would say, oh, we were really good. We're very well resourced. Actually, we got lucky. There were, if you look in the bottom table, there were a number of unprotected exposures, even in known SARS patients, even after the outbreak was known in that facility. And just recently in MERS in Indiana, same thing happened, where even after they were suspicious for MERS and they were sending off the diagnostic tests, they were using varying levels of infection control. And even after all of the procedures were in place, if you look all the way to the right, that blue and red, that's after everything was supposed to be in place. You can see there's over 10 exposures in that hospital. Fortunately, MERS is variable in how it spreads, and there was no human-to-human spreading in this particular case. But the potential was there. It's not because we were good, it's because we got lucky. So I don't think as a critical care community we're going to be the ones that really reduce the number of zoonoses in the world, but we can reduce the impact. Right? So it's going to be the event happening and the vulnerability. And the vulnerability is currently glaring, and it's up to us to start reducing that vulnerability so that when zoonoses do happen, they actually just get really good care and they don't take down our ICUs and our hospitals. So the unannounced contagion needs to be a never event. And again, the current strategies led to unprotected exposures. What I would argue is we need to have much better admin and environmental exposures. We need to reduce the level of exposure to almost the point of safety and then use PPE as our fail-safe. But the PPE should not be the linchpin of a strategy for a disease we don't even know that's in our hospital. And just going back for a second, honestly, though, at the same point, we still need to get better at using PPE. So admin controls, those are things like policies and procedures to be able to protect us and getting smarter about how we do our process. Environmental controls, so if you think about droplet nuclei, which is what we worry about for airborne spread, right now our big way to utilize that is we use airborne infection isolation rooms, or what we used to call the negative pressure rooms. There's not very many of those, right? And even the way they work is they're constantly changing air and moving air out of that room where it doesn't interact with the other clinical space, and it goes either externally or it gets filtered before it goes back in. So the idea is, again, to reduce infectious burden. Makes sense. If you look up on the right, though, it takes up to about an hour for standard either 6 exchanges, which are what all old hospitals have, or 12 exchanges, which are what new hospitals have, before you actually make it where it's a really safe environment. So it's a good start. We don't have very many of those, but those are the kind of things we need to start thinking about. And the other stuff is there's been a lot of just not interest because either it's too expensive or we're not sure about the utility. And I'm not saying this is the right technology, but UV germicidal radiation has been known for decades and decades and decades. And it's been demonstrated to reduce TB burden back in the old Riley study. And recently in South America, they repeated this where they took the exhaust of a room with patients with HIV and TB and exposed guinea pigs, to the exhaust air, and looked at which of the guinea pigs got TB. And the study was one day they would turn the UV lights on, and the other day they would turn it off. And if you look at the right, there was a lot of protection for the guinea pigs that the air was already being sterilized by UV irradiation. So again, I'm not saying that we need to go out and put these lights in everywhere, but we need to change the conversation. The environment needs to protect us. It shouldn't be at 3 o'clock in the morning, the intern or the house staff having to think about, is this a patient who's going to kill me and do I need PPE? Yes, we need to teach them that as well, but that should only be the last part of the security strategy rather than the only way we protect our facility from infection coming in. We also need to get better at how we clean rooms. This is from the University of Maryland, where we looked at whether or not we could grow MRSA and other bacteria from our high-risk areas with patients in there in the ICU. And lo and behold, we could. Even with intensive cleaning, though, we still could. So there was a reduction, but it didn't go to zero. So I think we need to really have the conversations that we need to have an environment safe so we can take care of our patients. And lastly, I think we should rethink PPE. The current PPE is okay, but it gets in the way of how we have to do our business. Why can't we work with industry and other places to redesign the PPE so it actually works with our workflow so we can use it rather than finding that it's just in the way of trying to take care of patients? And I know this requires investment, right? Everything does. But it's pay now or pay later. SARS alone cost the world economy $45 to $50 billion. Right? Only 8,000 patients. It was an outbreak that lasted less than a year and had an enormous economic impact. I think we need to change the way we do business and the risk that we have to ourselves. So changing gears, that's for unrecognized infection. What happens when either you're at a hospital and there's infection known already in a local area, or it's actually in your hospital already and you know? Well, take a deep breath. You don't have to start from scratch. The good thing is there's a lot of systems in place in which to organize and coordinate around. And I would argue, well, some would argue that going rogue is good. I think others would argue going rogue's probably a nightmare strategy, and I would say it is. ICU folks, we like to take charge and lead. And it's important that we're at the table making sure that our staff are safe. But the key thing is we need to do it within a system that's integrated and coordinated with all the other things that are happening in the hospital. Because there are a whole bunch of cats you have to herd to be able to make sure that the response can happen. And if we have lone wolves going off and kind of making their own plans, even with best of intention, it's ultimately going to work at odds to the overall response. So what I would argue is we need to integrate into the system rather than take over the system or just build our own. So what happens once infection's there? Well, infection control will look and they will predict what is the mechanism of transmission. And this is the basis for what is the paradigm right now, which is transmission-based recommendations. That's where you hear about droplet, contact, airborne, etc. And then there are environmental procedures or environmental applications that are linked to that and certain PPE as well. So when you get the PPE recommendation, the thing we need to realize is not just buying the PPE. It's actually that we need to be able to use it in a way that we do not self-contaminate. And probably we can do a lot of learning from a number of our human factors, our ID colleagues, at how to use PPE better. The flip side, though, is I think we need to be at the table, not just accepting PPE like it came down from the mountain, but being able to talk about how is that going to work in our environment. The first time I was in an Ebola treatment unit, I can tell you, the first thing I thought about is, excuse my French, this shit better work. Right? You're in there and you're worried. The second thing is when I bent down on the ground to pick someone up who was vomiting under a bed, my elbow hit my face mask. Right? And then you start realizing, wait, there's ways I can bend, there's ways I can move. If I stretch my leg out, I won't rip my PPE. So that's the kind of stuff critical care providers need to be at the table talking about, because we're the ones doing most of the patient care at the bedside, and specifically our nurses, our techs, etc. Being able to talk about what are the physical challenges so that we can actually keep people safe. And this just says that if we do train, though, we can get better. So it starts with people who self-contaminate a lot. You can get better immediately. And the good thing is it actually sustains for a little while. But I would argue probably there's attrition after that, and then it goes right back to the beginning. So as I mentioned, critical care needs to be at the table because some of the things that we deal with is different than any other unit, or at least us in the emergency department, maybe the operating rooms. Because of the way that we provide access to the airway, and because respiratory infection is likely going to be the biggest way these things get into our hospital, we need to really be talking about, is the PPE appropriate, and are the environmental controls appropriate for our patient population? It's very different what you're going to do for an outpatient at a clinic versus someone who's coughing on your ventilator. Laura Howley-Rook wrote some really great articles both during SARS and after SARS, and her after-action reports are really quite profound. And I think her sentence right there about the uncertainty has been played out multiple times. When we go into these events, as much as some people would like to tell us we know everything about the transmission, we actually go in blindly. The transmission is not known, and especially not known about the interface with life support equipment and that transmission. For instance, Ebola is unlikely to be respiratory transmitted in Africa because people who maybe started to shed from their upper airway actually died before we even were able to have them transmit that way. In addition, we had no oxygen. That's very different than the folks who came back to the U.S. and in Europe, where respiratory failure was not uncommon. So I think we need to make sure, again, not that we just throw stones and say we don't believe you, but we need to challenge the expected, just accepting of this is the way transmission is, and be colleagues and be able to mention to folks there may be differences, and we need to be at the table to make sure it happens. And what I really think we need to do is we need to start encouraging science to happen in an outbreak. And I'm not talking about research. Research is a different thing. I'm talking about guidance, about saving lives, saving our lives in the midst of the outbreak. There's a lot of science already going on during an outbreak, but there's very little focused on how do we reduce transmission in the ICU. There's science that's already out there, although we can argue about the techniques of how to do air sampling and environmental sampling. But could you imagine, rather than the CDC sending a group it's just counting patients, but they come in and they actually do air sampling, environmental sampling, when you're using either non-invasive or you're using high-flow oxygen or you're using mechanical ventilation, and actually the circuit splits, and they tell you what is the risk, right? That's what we need. Because with the uncertainty, you know what happens? We just get blamed if we get sick. They'll say, I know the person doesn't remember an exposure, but there had to be an exposure. And that really doesn't keep us safe. And that creates us at odds with the people who are trying to help us respond. And we don't want those challenges separating us when we need to all come together during an event. So just the last part of my talk is just going to mention the difference between operational information and research. And I think all of us too, especially when we wear our academic hats, want to be able to enhance our academic careers from certain outbreaks. The downside of that is early data is crucial to all of us getting through this. Early data keeps us safe. Early data protects our patients. And we really need to be able to come up with a way to allow institutions that are impacted to still get their benefits of their information afterwards. But during the outbreak, they need to be able to work together with others to get that information out. And if they don't have the resources to do that, they need to allow others to come in and help them. It doesn't mean they'll be usurped, but we need that information immediately to be able to figure out what's going on so that we can save our folks. And I'll tell you, that strategy, after spending years in HHS and public health, is not on the table. It's just something that's not in their priority list, not because they don't believe it. It's just they're thinking about case finding and contact tracing. They're thinking about vaccine, and they're thinking about therapeutics. All very important things as part of the outbreak. But for us, we need to figure out how to keep us safe and take care of patients properly, and then the rest of it can come. And unfortunately, this scenario, time and time again, we miss these opportunities because no one has really taken the bull by its horns. And I think it's time the critical care community as a group and SCCM as an organization says, you know what, this is something we want to see change. Now, when you're in your ICU, you're still going to be having to put a multidisciplinary and multi-professional team. Obviously, you're working overall in incident management, but again, there are going to be key things that are going to be specific to your ICU. How are you going to approach intubation? What are you going to do for oxygenation that really a lot of other folks aren't going to be thinking about? It doesn't mean you need to do it yourself. It's great to reach out to colleagues in unimpacted areas and ask them to do it for you, but ultimately, you're going to need to implement it in your own unit. So what do I think we should do as a community? I think we need to bring the issues that keep not getting dealt with to the table. Again, not because we're upset about it. We just know that these are things that we see in our perspective that other people just don't think about because it's not what they do. So I really worry about the way we do supplemental oxygen. And there's absolutely no guidance on how we utilize that during outbreaks. We need to figure out a variety of strategies, even while they'll seem like minute detail, they may be a big thing. Should we be using heated wire ventilator circuits so that we don't have to break the circuit all the time to remove condensation? And again, you may say, that's so in the weeds, but that may be the difference between 6 people who are in a room who actually get ill versus someone else. And it doesn't always need to be the local ICU doing it. It can be us working together with AARC and other groups to be able to really take the advantage of all the expertise in this country and in the world to come up with that guidance. But if we don't mention that we need it, it's never going to get done. So the world has enormous resources, and I've seen them brought to bear. I've been part of the government machine responding. There's a huge amount of resources. The problem is they're just not focused on what we focus on. And I just want to give you an example that things do happen very quickly when they're resourced. During SARS, the outbreak happened in March. The virus was isolated and identified by a cancer group of all folks in Canada within 2 months. That is just earth-shattering, right? Same in MERS. After the first outbreak was actually identified, so if you look at the second red, that's where the first one was identified. They learned previously that there was an outbreak in Jordan, but only figured it out retrospectively. So when KSA had the first outbreak, they sent samples to the Netherlands, and they were able to identify a new pathogen almost immediately. The world worked. Resources worked. And now they were able to ultimately generate a diagnostic test from that. And you can see how all things get better. We need iterative improvement. We need to have resources brought to bear for us to be able to do the same thing. And it can be done. Gail Thompson and her group in the UK during the 2009 H1N1 pandemic had already had a protocol in place at trying to figure out what different things spread virus in terms of aerosolized generating procedures. Because previously, aerosolized generating procedures was just made up. No one really knew if they truly aerosolized or what risk there was. So Gail's group actually studied it in the midst of the outbreak, and we got smarter. And I think that's what we need to do to be able to reduce that uncertainty, to reduce the fear of our staff so we can actually respond appropriately. So in just my final minute, I just want to kind of bring together a broad infrastructure for how we change what we do. Again, it's not just about buying the widget. It's about all of us at the different levels that we play a role in critical care, actively working together to ensure that we never have infection to our patients or to our staff. In addition, our critical care organizations, we actually could play a huge role during a disaster. So while SCCM is not exactly an operational unit, right? We're not going to put them in the field. That's not probably the wisest place for them to be. They are a great place to organize information dissemination, right? So put a conference call together. Have some of the critical care clinicians who are experiencing this stuff share their stories with other folks, but make it bidirectional so that they can ask for assistance and other people can step in and provide them assistance. It shouldn't just be talking about we're in a whole bunch of hurt and this is what's going on. It should be this is what we're experiencing, this is what we think you should do. In addition, we need this assistance. Is there anyone out there who can help us? We need to make these responses better. So it's up to us. We can choose the path and just accept all the stuff that's done to us, or we can just do it. Thank you very much.